Our next speaker is Dr. Clifton Q. Dr. Q is the Medical Director of Kidney and Pancreas Transplantation at the University of Alabama. UAB was a participant in the early development of TruGraf. Dr. Q will share with us the longer-term follow-up of the UAB patients that were monitored using TruGraf. Dr. Q.
Some of the issues of doing surveillance biopsies at a busy transplant center. Well, we're a large center. We're the only transplant program in the state of Alabama. We usually perform more than 250 kidney transplants per year. And trying to arrange all these surveillance biopsies creates some logistical problems. So at our center, some of the key issues are overburdened staff. I mean, we never feel that we have enough people to get the job done. We need people to call the patients and arrange for them to come in. We need to make sure that they've taken their antihypertensives. We need to make sure that they're NPO and all that sort of stuff. And then we have to find a place for them to get their biopsy done. Frequently, our ultrasound suites are overbooked, and it may take several weeks in a surveillance situation to get those biopsies scheduled. And then we have patients that say, hey, I'm doing okay. Why do I even need to come in? And I feel great. I don't think I need a biopsy. We also have patients on anticoagulation, and now we have to do some thinking because now we have to weigh the risks of withholding anticoagulation versus the benefits of having the biopsy. And there may be patients that we would never want to hold anticoagulation, and patients that come to mind are those that are on or that have mechanical heart valves. And then we have a huge area that we serve between 250 miles or more from Birmingham. And there are people that just don't have the money to come in for an extra visit. And then the current COVID-19 pandemic, patients are simply reluctant to come in because they don't want to get exposed. And we recently opened up our evaluation clinic and are having difficulty filling slots because patients are genuinely afraid. And then the pathologists, because they're already reading all the 4-cause biopsies that we do, all the time zero biopsies that we do, all the native biopsies that we do. And now we're adding another 200 or so additional biopsies for them to read. So I think that a blood test to reduce the dependence upon surveillance biopsy would be an asset, a major step forward for a program such as ours and for probably many programs across the country. So what did we do? So we looked at 116 consecutive kidney transplant recipients. At our program, it's standard of care for all our patients to have a surveillance biopsy at 6 months. And we do not just a biopsy, but we do a donor-specific antibody, we do a PK-PCR, we do medication doses and levels. And so we do this whole, what we call an immune surveillance. For the biopsy, both a creatinine and TruGraf were collected. The TruGraf results were compared with histology. And we also did a survey of the investigators on the clinical utility of TruGraf to see if they felt comfortable ordering TruGraf in the future. So of the 116 kidney transplant recipients that were assessed, 26 were excluded because they ultimately never had their biopsy done, or there was a quality control issue with the test. So the final analysis included 90 patients, 59 were deceased donor recipients, and 31 were living donor transplant recipients. The demographics were kind of what we would expect to see in a program such as ours. 60% were African American, 37% were Caucasian, the remainder were Asian and Hispanic. The mean age was 49 years old, with a range between 21 and 78. 60% were men, 40% were women, and the mean serum creatinine was 1.38. So what did we find? In 8 patients, both the biopsy and TruGraf were not TX. They agreed with each other and said, hey, there's a problem. In 57 patients, the biopsy and TruGraf also agreed that everything was okay. Both were TX. There were 15 false positives where the TruGraf said, hey, there may be a problem, but the biopsy ultimately showed everything was okay. And then in 10, there were false negatives where the biopsy said there's a problem, but the TruGraf result was TX and said everything was okay. So what were the performance metrics? Well, the accuracy was 85%, the negative predictive value was 81%, positive predictive value was 40%, sensitivity 44%, and the specificity was 78%. So how did we fare with clinical utility? Well, here are the three questions that we asked. The TruGraf results support your decision on how to manage a patient with stable serum creatinine. Answer yes or no. Number two, how did TruGraf support your decision? Did it indicate the patient is stable and no intervention is needed? Supported a change in patient management, informed need for additional testing, informed the need for a biopsy, or supported avoiding a biopsy. In question three, does TruGraf result encourage you to use TruGraf in serial testing in future patient management? And the answer to question one was 77% was yes, and the TruGraf supported the decision on how investigators answered A and E, 71%, that indicated that the TruGraf result indicated the patient was stable and no intervention was needed, and supported avoiding a kidney biopsy. And the answer to question three is that over 3/4 said that they would be encouraged to use TruGraf in the future in a serial testing fashion. In summary, TruGraf correctly identified 57 patients whose biopsy could have been avoided. So that's 57 procedures that could have been avoided. And even though the risks of allograft biopsy are pretty low, when they do happen, they can be catastrophic. So if we can avoid any biopsies, I think it's to the benefit of our patients. TruGraf correctly identified 8 patients whose biopsy was justified. So these are people TruGraf said not TX. And so those people, we would proceed with a biopsy to make sure that that's the case. On the other side, there were 15 patients that had a biopsy unnecessarily because TruGraf was not TX, but the biopsy came back TX or everything was fine. And then there are 10 patients where subclinical rejection would have been missed. 7% of the clinicians reported that TruGraf supported their patient management decisions. So what does this all mean? Can we avoid surveillance biopsy? The answer, I think, is yes. And I think using TruGraf would help. What are some things that we can do to maybe increase the accuracy? Well, we can look and try to stratify some of the patients. There may be patients that I don't care what anything says, they need a surveillance biopsy. There may be patients that maybe we can. Maybe we could do proactive serial testing. And if we get so many not TX, well, they need a biopsy. Could we throw donor-specific antibody results in, kind of modify our decision-making? Should we take into account medication levels and doses or history of non-adherence? Maybe we should take into account the sensitization status of the patient and kind of determine what we're going to do based upon a combination of all these things. But what are some of the other applications of TruGraf in a program such as ours? So could we use it to as a monitoring tool during minimization of immunosuppression? So you've had your TX. Maybe you don't have a lot of risk factors for immunologic injury. Maybe we could just keep checking a TruGraf to make sure we're doing the right thing by cutting back on the medicine. Could we use it as a tool following the treatment of rejection? So somebody's not TX, we do a biopsy, they have rejection, we treat them, and then we could monitor them afterwards and make sure they're TX afterwards. What about evaluating patients on anticoagulation or those that just can't get to the transplant center? I mean, we have the proverbial patient that lives in Mobile that's 250 miles away. They bump their creatinine, and maybe the better thing to do would be to get a TruGraf, a DSA, and those things are not abnormal to have them stay down there. Or if they do come up with a problem, then I think we would be more justified to bring them up to clinic and risk getting some kind of an exposure. So TruGraf has some really important advantages in all these situations because I can manage patients locally. That would be good. So I'd like to thank Roz Mannon, who really spearheaded this work while she was here at UAB. She's currently at the University of Nebraska Medical Center. Audrey Ange, who's a medical student and is going to be graduating from medical school next year. She put the data together and was really instrumental in getting it into a form that could be analyzed. And of course, I'd like to thank Transplant Genomics and all their support for getting this done. I encourage everybody to come virtually and see the poster, board number C336, and check it out. Thank you very much. Have a good day.